Okay, so now we're going to dive into various organisms, specifically bacteria, that cause disease. The first genus we're going to talk about is Staphylococcus. In this image here, you can see Staphylococcus with blood cells. The purple clusters of circular organisms, those are the bacteria. Staphylococcus, in general, they are gram-positive. The genus is also catalase positive. You might remember catalase is an enzyme that degrades hydrogen peroxide into oxygen and water. This is an important immune evasion strategy because hydrogen peroxide is produced by the immune system to get rid of bacteria. This is one of the quickest and easiest tests you can do for a bacterium. It's one of the easiest biochemical tests. You put some bacteria on a slide and you add a few drops of hydrogen peroxide. If it produces bubbles, that's catalase. If it doesn't produce bubbles, that's not catalase. Some of the other gram-positive coccus-shaped organisms are not catalase positive. So if you find a gram-positive coccus that is catalase positive, that can lead you towards Staphylococcus as a potential cause of the infection. What I want you to think about as we go through all of these organisms, and what I hope you take notes on and reflect on, is how you, as a medical professional, would be able to differentiate these different types of organisms. And you want to pick things that are big and broad, like gram-positive versus gram-negative, shape, and various biochemical assays. Because it's one of those situations where when you're talking to a patient and the patient asks you, what do you think is wrong with me? You don't want to be out there going, well, let me Google that for you real quick. So a lot of this information, it's really important that you have it on the tips of your fingers. Staphylococcus, in Greek, it basically means grape-like clusters. So when you look at them under the microscope, they often look like this, which again can help differentiate them from some of the other gram-positive coccus organisms, but it's not necessarily diagnostic. So if you see that grape cluster, it's a good indication, but you would want to do additional tests to confirm Staphylococcus. Many are commensal, but they do cause opportunistic infections. One trick you can use if you want to differentiate Staphylococcus aureus, which tends to be a little bit more of a dangerous infection than some of the other Staphylococcus species, is that Staphylococcus aureus is coagulase positive. So it has an enzyme called coagulase. The other Staphylococcus species are coagulase negative. So if you happen to know that you're dealing with Staphylococcus from other tests you've done, you can differentiate Staph aureus because it's coagulase positive, meaning it can cause coagulation. So when you do a coagulase test, if you incubate with a different species of Staphylococcus, you see if you turn it on its side, it's still a liquid. If you turn it on its side and it's Staphylococcus aureus, it has solidified or coagulated. The virulence factors produced by Staph aureus and other staphylococcal species are under the control of an operon called the AGR, or accessory gene regulator operon. What we see with this organism, they are able to do quorum sensing, and when they're at a low cell density, so when they don't detect a lot of the autoinducer molecule, that promotes the genes that are helpful for colonization. So a lot of growth, right? Once they reach high cell densities, as determined by the concentration of autoinducers, that's when they will begin to produce the genes necessary for invasion and toxin production. And so think about that as a strategy. You don't want to cause symptoms of disease like tissue destruction or various toxin productions until there's enough of you to fight. Okay, so that's a really great strategy for them. Some of the virulence factors produced by Staph aureus include structural components like a capsule, a slime layer, or protein A. They produce various toxins like cytotoxins that will destroy cells, exfoliative toxins that cause tissue to come apart, enterotoxins which cause gastrointestinal issues, and toxic shock syndrome, toxin 1, which is a super antigen that overstimulates the immune system. Oh, I remembered that I mentioned the structural components. So a capsule and a slime layer are sort of similar in that they're these kind of gooey, sticky polysaccharide, structures, I guess. A capsule is usually a little bit more tightly packed and more densely surrounds the bacterium, whereas a slime layer is a little bit looser. I guess this is not really a scientific term, but it's a little bit more like snotty. Both serve a similar purpose in that they can help prevent phagocytosis because the phagocytic cells don't recognize that there's a bacterium under there. Protein A is a surface protein, and what protein A does is it binds to antibodies. And you might think, well, that's sort of counterintuitive. Why would a bacteria want to bind antibodies? Wouldn't the antibody trigger complement? And the answer is yes, an antibody would trigger complement. But if you picture the structure of an antibody as a Y shape, let's see if I can draw on here. Oh, I can. Okay, so I'm going to draw. So remember, we picture an antibody as a Y shape. And normally what would happen is if we have a bacterium like this, if the antibody binds and sticks out, this region, remember, is called the FC region. It's the constant region. Then the phagocytic cell will come in and it will engulf the bacterium because the phagocytic cell recognizes this FC region and eats the bacterium. So now I'm going to erase. Okay. So now what we have, let's say we have our bacterium and it has this protein A right here on the surface. It binds the FC region. So it binds to that FC region and it points out the Y like this. Well, the phagocytic cell looks at that and is like, what? So the phagocytic cell doesn't know what to do and won't phagocytize the bacterium. So this protein A, even though it binds antibodies, it basically binds them backwards so that the bacterial cell can escape phagocytosis. So all of these help, all the structural components help it evade phagocytosis. Okay, now we'll go back to, let's see, I don't want the pen. I don't want to draw on the slide some more. Let's just go to like a laser pointer. Okay, so now we'll go back and now we have our enzymes that can be produced. And this is not an exhaustive list, but it's a pretty good one. So coagulase, which can cause blood clotting, hyaluronidase and fibrinolysin, which help to break down various components of connective tissue like hyaluronic acid and fibrinogen. Also lipases, which can break down our tissue, especially our cell membranes, and nucleases, which can break down DNA. Now, in terms of epidemiology, everybody has some form of Staphylococcus on their skin. Usually that's going to be like Staphylococcus epidermidis in your nasopharynx, which is most often going to be, again, Staph epidermidis or maybe even Staph aureus, your GI tract or your urinary tract. And so for that reason, because people are generally covered with Staph aureus anyway, we often see these as endogenous infections. You make yourself sick because you already have this bacteria on you. And we also commonly see it as a nosocomial infection. So when I use this term nosocomial infection, I mean a hospital-acquired infection. Methicillin-resistant Staphylococcus aureus is becoming increasingly common, both just spread in the community and then, of course, in the hospital setting as well. It's estimated that approximately 2% of people carry methicillin-resistant Staph aureus, most commonly in the nasopharynx, and that about a third of individuals actually carry Staph aureus in their nasal passages. And I've taught laboratory classes before where we do swab our own noses, and that carriage rate is pretty accurate. About 33%, about a third of the class usually has Staph aureus. So it's estimated that MRSA causes 90,000 infections per year and 20,000 deaths. That's a lot. Okay, so what does Staph aureus infection look like in people?